GI pathology, peptic ulcer disease, ulcer complications, and acute GI bleeding. All right, so first and foremost, we have peptic ulcer disease. It can be located in two separate spots, or gastric ulcers or duodenal ulcers, okay? So first and foremost, gastric ulcers are going to be painful with meals. Okay, so as you're eating, it's going to be painful. And the reason behind that is because when you eat, you're going to have increase in acid production. The increase in acid production is going to irritate that ulcer in the stomach, and so that's why it's going to be painful while eating, okay? So you're going to see weight loss associated with gastric ulcer. Now, H. pylori affects like 70%, but NSAIDs is one of the main cause of gastric ulcers as well, besides H. pylori, all right? And you have an increased risk for carcinoma with gastric ulcers. So you have to biopsy in order to rule out malignancy for gastric ulcers. On the other hand, for duodenal ulcers, the pain's going to decrease with meals. And the reason behind that is because what happens when you eat is that you have the Brunner's glands producing bicarb, and the pancreas is going to produce bicarb. So it's going to kind of wash over the ulcers and kind of alleviate the acidic feeling and pain. All right, so you get weight gain because with eating, the pain is going to resolve on duodenal ulcer. Now, 90% of this is going to be due to H. pylori, so it's mainly going to be due to H. pylori for duodenal ulcers. All right, so other causes of ulcers is Zollinger-Ellison syndrome. Remember that if you see ulcers in the distal duodenum or the jejunum, then you know you're dealing with some type of Zollinger-Ellison syndrome. All right, now duodenal ulcers usually are benign. Okay, so we're not gonna biopsy them. They're rarely malignant. Okay, so that's kind of the key takeaway there. So the question is, what can happen with ulcer complications? Like, why are we so afraid of them? So the first thing that can occur is hemorrhage. So you can start to bleed from the ulcer, all right? Whether it might be gastric or duodenal. Duodenal is more likely to bleed when you have a posterior duodenal ulcer compared to anterior, all right? Now, what they want you to know is that a ruptured gastric ulcer on the lesser curvature of the stomach is going to bleed from the left gastric artery. So gastric ulcer is going to bleed from the left gastric artery. That's one thing that they want you to know, on the lesser curvature of the stomach. An ulcer on the posterior wall of the duodenum is most likely going to bleed from the gastroduodenal artery. Okay, so they want you to know these two high-yield things. You have to know those two, okay? Now, an ulcer can also cause an obstruction, relatively lower yield. And the last thing, and the most scary thing that we're worried about, is that an ulcer can cause a perforation. So duodenal ulcers are more likely to perforate anteriorly compared to posteriorly. Once again, lower yield. But what they want you to know is that the patient is most likely going to present with pneumoperitoneum, all right? And so what does that mean? That means that you're going to have air within the peritoneal cavity, right? Because one of your outside, like remember, the GI tract is just all outside. So right when it perforates, there's going to be air within your body, which shouldn't be there normally because it's in our hollow organ system, the GI tract. So right when it perforates, it's going to release air into the peritoneum, known as pneumoperitoneum. Pneumoperitoneum is always pathological. It's always pathological. Air should not be inside our peritoneal cavity. And so what happens is how we're going to figure this out is that the air is going to rise. And so on chest x-ray, upright chest x-ray, you're going to see air under the diaphragm. Okay, and that's known as free air under the diaphragm, pneumoperitoneum. It's literally just pathopneumotic. Okay, so look at what that looks like on chest x-ray because they will show it to you 1,000,000 times, and that will be a dead giveaway that there's some type of pathology going on where you have had essentially a GI perforation. Throughout somewhere in the tract, there's some type of perforation, there's some type of leakage, okay, that's getting air under the diaphragm because pneumoperitoneum is always pathological, all right? And the air in the peritoneum can also cause phrenic nerve irritation. So the patient can also present with referred pain to the shoulder, right? Because remember, phrenic nerve irritation will always have referred pain to the shoulder. So that's another sign of free air under the diaphragm, another sign of pneumoperitoneum, okay? So that is one of kind of the ulcer complications that you're scared about is perforation. All right, now back to the hemorrhage. If you have acute GI bleeding, it's going to be separated based off of where the bleeding has occurred. So upper GI bleed versus lower GI bleed. For upper GI bleed, it's usually going to originate proximal to the ligament of Treitz. And the ligament of Treitz is just kind of at the way that I think about it is that it's kind of at the second part of the duodenum, all right? And so if it's proximal to that, it's an upper GI bleed. And usually the patient is going to present with hematoemesis or melena. So they're going to have bloody vomit or they're going to have black stool. Okay, the reason behind that is because the blood has time to be digested and broken down by some of the acid from the stomach still if it's an upper GI bleed. And so when it gets digested and it gets broken down, it turns black rather than being bright red. Okay, so that's why you see melena or black stools. Okay, on the other hand, if you have a lower GI bleed, that's going to be originating distal to the ligament of Treitz. all right? And so the patient's going to have bright red stools, okay? And those are our differences between upper GI bleed and lower GI bleed. And there's going to be multiple things that affect upper GI bleed. Upper GI bleed is associated with like peptic ulcer disease, as we said, if it hemorrhages or if it perforates. Also with varicocele bleeding, right? If you have esophageal varices and they start to hemorrhage, you can see hematoemesis or melena later on. Lower GI bleed is associated with like irritable bowel or inflammatory bowel disease, diverticulosis, hemorrhoids, anal fissure, cancer, okay? So keep in mind the differences between the GI bleeding.